بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Our lecture today about ABG and Hypoxia, diagnostic approach and management. Okay, let's revise this was put in the last taken in the last lecture. Normal pH, PaCO2, PE2 saturation by carb, made hemoglobin, carboxyhemoglobin, and disease excess. The normal values pH, as you know, 7.4, okay, plus or minus 0.05. PaCO2 is 40 plus or minus 5. PO2 is from 70 to 100. Saturation from 93 to 98. Bicarb 24 plus or minus 2, methemoglobin less than 2, and carboxyhemoglobin less than 3, and the base excess from minus 2 to 2. The cable to blood gas interpretation, there is 3 physiological equations: alveolar gas equation, and oxygen content equation, and Henderson-Hasselbalch equation. Everything will be illustrated later. Systemic oxygenation. Paul Marino said oxygen may be necessary for life, but it doesn't prevent death. What's mean? That oxygen is a supportive measure, okay, not curative. So it will not treat the cause, but only support, okay. So it's necessary for life, for life, but doesn't prevent death. So if a patient is hypoxemic, we should give to him oxygen as a supportive measure and treat symptomatic, but it will not prevent the cause, and if the cause is persist, there will be further deterioration of his hypoxemia, and the oxygen will not cure the condition and will arrest it from hypoxemia at the end. Oxygen content. There are many oxygen content. What is meant by oxygen content is the concentration of oxygen in blood, okay. The oxygen in our blood, it forms of in two forms: bounded to hemoglobin and dissolved. The bound to hemoglobin is the carrier, okay. The hemoglobin is the carrier for the oxygen. Why it is bound to hemoglobin? Not all our oxygen is dissolved, because the solubility of the oxygen is poor, okay. The second thing, when oxygen is dissolved in high concentration, it will form oxygen-free radicals that will be more dangerous and cause cytotoxic effect on the cells, okay. So there will be carriers for the hemoglobin, which is most of the about 98.5% of all our hemoglobin content, and the dissolved in the plasma is the functional oxygen, okay, which about 1.5. So all our oxygen content will be the sum of both the bounded oxygen to hemoglobin and the dissolved. So the bounded oxygen in hemoglobin, what is the parameter that it will depend on? Will depend on two things, okay. First, how much hemoglobin you have, okay, for each person. The second is how much saturation, which is the percentile of hemoglobin that is saturated with oxygen, okay. What is this number? 1.34. 1.34 is the oxygen binding capacity of hemoglobin. So it is, what's mean by that? That each gram of hemoglobin can be saturated with 1.34 milliliter of oxygen, okay. So this is the constant. What's the dissolved oxygen? The dissolved oxygen is, as the oxygen doesn't dissolve readily in the plasma, so we need carrier, as we said before. The solubility of oxygen in the plasma is temperature dependent and varies according to the body temperature, okay. The dissolved oxygen, the equation is 0.003 in the oxygen tension, or PO2. What means by PO2? It's the partial pressure of oxygen. What's meant by the partial pressure of oxygen? If there is a total pressure, yes, it's a total pressure. Once it's a partial, so there was a total. What's the total pressure? The partial pressure of a gas, it is the pressure formed by the movement of the molecules of the gas. Okay, so partial pressure of oxygen is the pressure formed by the movement of the molecules of oxygen. The total pressure will be the pressure formed by the movements of all the molecules, okay, of the gases, including oxygen, CO2, nitrogen, water, okay, and others. Okay, one moment. Hello? conference okay, so this is the total oxygen, the total pressure. So the dissolved oxygen is 0.003 by multiplied by the PO2. So the arterial oxygen content will be the sum of both, as we said. 1.6, this is the bound and this is the dissolved. Okay, 1.34 by hemoglobin by saturation, and this is 0.003 by the PO2. Okay, the normal arterial oxygen content is about 20 milliliter per deciliter. So if we calculate per liter, will be 200. Okay, how much of this 20 or 200 is dissolved and how much is bound? As I said before, 1.5 is dissolved and the majority, okay, is bound to hemoglobin. Okay, so it's 98.5. The venous oxygen content here there is a question. What is it? The total volume of oxygen in the arterial blood is more than the venous blood or less? Yes, the absolute number. More than venous or less? No, it's less. Why? The oxygen saturation in the arterial is higher than the venous. Sure, okay? Except in one situation. But here, the saturation is not the only parameter. It's a very small parameter. The main parameter is the hemoglobin. Okay? So the hemoglobin content, okay, in the venous blood, the venous reservoir is a capacitant, okay, and it contains about 75% of our blood in the veins, okay. So the total amount of oxygen will be in the veins, not, okay. Although the saturation and functioning will be in the artery, yes. 75% of the volume of the blood in the veins, so the total volume of oxygen in the arterial will be less than the half volume of the oxygen in the venous blood. Okay? The venous oxygen content as above, but instead of A will be V. Venous content of oxygen will be the same equation, but instead of A will be V, saturation of vein. Okay? And here will be the PVO2 instead of PO2. The normal mixed oxygen venous. There are two types of, where in the practice we have to, the oxygen, when we want to take a sample for the systemic veins, okay, oxygen saturation, can be taken from one of two parts of the body. Either from the right atrium or from the right ventricle. If it's from the right atrium, we take it almost from the CVP, so it is termed central venous pressure, central venous sample, okay, or central venous oxygen saturation. If it's taken from the RV, it's called mixed venous. What's the difference? You expect the RA central venous as mixed venous, or less or more, and why? More oxygen saturation or less? Less than excellent. لا شذا جاي. Okay, the right ventricle is less. Okay, the right ventricle is less. It's the mixed venous, while the right atrium is the central venous. Yes, the central. While because superior vena cava and inferior vena cava will drain the blood into the right atrium. Okay, and then to the right ventricle. The right atrium contain all of the venous stream from all the body except the coronaries. Okay, of the heart, the coronaries will pull the blood through the coronary sinus, which it's opening in the right atrium, but it's directed towards the right ventricle. Okay, and they mix it in the right ventricle, become mixed of the systemic and the coronaries. Okay, to become less about 3 to 4%. We revise some of the last session. Okay, for our new resident. Okay, and continue. So the mixed venous is less. Okay, the mixed venous is about 15 milliliter per deciliter. Okay, the oxygen content in the mixed venous, and we said in the last slide that the oxygen content in the arterial is how much? Is 20. Okay, it's 20 milliliter per deciliter in the arterial, and it is 15 in the venous. So the difference between the arterial and the venous, where it went? Went to the tissues. So it is uptaken by the tissues. So the difference between the oxygen content of the arterial and the oxygen content of the venous will be what's uptaken by the tissues. That will be 5 milliliter. 20 minus 15 will be 5 milliliter per deciliter, or if we, in terms of liter, will be 50 milliliter per liter. Okay? Which means that 50 milliliter of oxygen is extracted from each liter of blood flow through the capillaries. So we have a normal cardiac output about 5 liters, okay, per minute. So our oxygen uptake from the whole the body will be how much? 50 multiplied by 5 liters. It's 50 milliliter of oxygen per liter of blood. Yes? So will be 50 multiplied by 5 liters of blood to be, okay, 250 milliliter of oxygen per minute for the whole blood. Okay, it's clear? So this will provide information about the tissue oxygenation. For a simplified oxygen content equation, as we said that oxygen content equals the sum of both bound oxygen to hemoglobin and dissolved. And as we discussed that the dissolved is very minimal, about 1.5%, and 98% is from the bound oxygen. So we can neglect the dissolved in the total calculation, okay, to be a simplified equation, and the oxygen content we can consider it 1.34 by hemoglobin by saturation, and 1.34 is the, what is this? As we say, okay, this is the oxygen binding capacity of each gram of hemoglobin. So each 1 gram of hemoglobin can carry or bind maximally about 1.34 milliliter of oxygen to be fully saturated. Okay, this is the constant. Okay, Dr. Marwan. So this is a simplified equation. Okay, so the last sentence here summarizes that oxygen content of the blood thus equivalent to the hemoglobin bound oxygen. Okay, what is more important, anemia versus hypoxemia? If we have two patients, okay, and have both of them have reduction 50%, okay, in his PO2, okay, oxygen tension, which is the dissolved. The dissolved is, the equation is 1.003 in the PA2 is the partial pressure of oxygen. Okay, or we have reduction in 50% in his hemoglobin. This was the equation why I okay, this, okay, 1.34 in hemoglobin saturation, and this dissolved in PO2. If we have reduction in this, so we have reduction in the dissolved, okay, or we have reduction in this, we have reduction in the bound by the same percentile. You expect which is more critical and what will result in more decrease in oxygen content? The hypoxemia or the anemia? Anemia, yes, of course. Okay, why? Because the anemia, the hemoglobin represents about the major carrier and about 98%. Okay, so in this by numbers, okay, if we reduce the hemoglobin from 15, okay, for a normal person, okay, this is the hemoglobin, okay, and this is the oxygen content. Okay, as we said, the oxygen content is about how much in the arterial? 20. Yes, 20 milliliter. And here how it's the hemoglobin is 15. Okay. Okay. How it come 20? 15 multiplied by 1.34. Okay. 1 by 15 is 15. 0.34 by 15 is 5. 15 plus 5 equal 20. Okay. If the saturation is 100%. Okay. This is equation, yes? Clear? Clear or not? 1.34 hemoglobin multiplied by saturation. Saturation is 1 because it's 100%. Okay? 1.34 multiplied by 15, how equal? It will be 20. 1. It will be 1 in 15 and 0.3534 in 15. Okay? 0.34 in 15 will be 5 and 1 in 15 will be 15. Okay, so 15 plus 5 will be 20. Okay? It's clear? So if the patient, his hemoglobin decreased from, this is from 15, it's normal, to 75. It decreased by how much? Half. Okay, 50%. So its oxygen content will be 7.5 by 1.34. Okay, that will be equal 10. Okay, and his saturation is normal. Okay, but the other patient, if his PO2, his hemoglobin is normal, but only the PO2 it is decreased. Okay. Okay. So the only the dissolved. So if the PO2 decrease from 90 to 45, the saturation will be how much? If we for normal person, normal person with 92 saturation equal how much PO2? What's mean by hemoglobin saturation? Hemoglobin saturation equal to, and it means that it's a percentile of hemoglobin that is saturated with oxygen. Okay, so if it's 100%, so all of our hemoglobin is fully saturated with oxygen. Okay, if it is 90%, so it's 90% of our hemoglobin is fully saturated with oxygen and 10% is not saturated with oxygen. It's clear? What's the how the hemoglobin is saturated with oxygen? As we see, okay, when I inspire air, okay, containing oxygen, it will, my nose, upper airways, lung, and alveoli, okay, will be the inspired air containing oxygen with a pressure, okay. This pressure formed by the movement of the molecules of the oxygen, okay. This is the alveolar PA capital O2, okay, the alveolar pressure of oxygen, okay. And with the pressure difference, with pressure gradient, okay, will pass to the pulmonary capillaries, okay, will pass and dissolve it or bound or pass become dissolved, okay. And after that, with the pressure gradient from the dissolved from the blood plasma, okay, will go to the hemoglobin. Okay? It is an oxygen cascade from the higher pressure to the lower pressure, okay. How much PO2, okay, pressure we need to saturate 100%? How you expect? It's present in the oxygen saturation curve. This is what we are talking about. How much PO2 is needed to saturate the needed amount of hemoglobin. Okay? For 100%, okay, we need almost about 80, okay, to 90%. There is no problem here because this is the plateau portion. And also here this is the plateau portion. Why this curve is sigmoid or S-shaped? This curve is sigmoid or S-shaped because we have 4 molecules of hemoglobin. Okay? Each molecule of hemoglobin has four atoms of iron. Okay? The atoms of iron, Dr. Marwan can give me your hand. Okay? Are like this, where our knuckles, this, okay, represent the receptors for hemoglobin, for oxygen. So they are not exposed. So the first oxygen atom, okay, comes to bind to hemoglobin, to the iron, okay. It will be the very difficult, the most difficult one, okay. Once the first is bound, there will be a conformational change, thus the receptors become outward. So the second and third and fourth will become easier and easier. So we will see it is plateau, the steeper portion after the conformational change and the receptors become out, okay? And this, after that one, it's almost saturated, so become again plateau. So this is why the S shape, okay? The critical point of this, and you should understand this, that when a patient with a saturation on the monitor is 92-93%, it's okay. Okay. Once saturation decreases less than 92%, it's very critical for me. Why? This is a 92%. Now I lost the plateau portion. So the unloading, it's the same in the loading and the unloading of oxygen. Okay? So if the patient is on here, when he's 92, his PO2 is 50. It's 82. When he's 92, okay, it will equal to 60. Okay? And it's for me it's sufficient. Okay? 60 and with 92 percentile or 90, it's okay. Below 90, it's very critical. Okay? We will go to the steeper portion. Okay, sorry, it's 90. Okay? We go to the steeper portion. So if it is on 80 or 82, it will be 50. If it's on 70, it will be about 35. Okay? Although the number here is not changed more from about 10 to 15%, but here you may be at 90 or 80 PO2, okay, with the saturation 100%, you decrease to 35. Okay? So it's severe hypoxia. It's clear? So after the patient becomes desaturated to this, to 80s, okay, you consider to him to a dramatic change in his hemodynamic status and oxygenation. Okay? So what we was discussing that the hemoglobin, okay, how much of PO2 you need to load the percentile of hemoglobin you want. Above 60 is safe. Okay, 60. Okay, with the blue curve here, it is the normal. When 60, it becomes about 90. Okay. So here, when what's the this is PO2, this PO2 90, it's equal about saturation 100. Yes. Why we discuss this curve now? Okay. Why PO2 is 45? How about the heat saturation? Will be about 78, 80, okay? About this, yes? So when we decrease the PO2 50%, the dissolved oxygen 50%, okay? What about the oxygen content will be decreased? It's only 4, okay? It will be 16. While we decrease the hemoglobin 60%, it dropped to 10, 50%, okay? It's 16. When we decrease the PO2 50%. While when the same PO2 and saturation 100, but his head decrease in hemoglobin, the oxygen content decreased by 50%. Okay, it's clear? So anemia, it is very more critical than hypoxemia. Okay, so in sepsis, for example, in sepsis, we are many methods, okay? It's algorithm, okay? And sepsis bundle to how to treat the patient. At the end of the algorithm, after fluid resuscitation and vasopressors, okay, we will check for the mixed venous oxygen saturation, okay? Why? We'll illustrate after that and return to it. So as we discussed, the oxygen content will be simplified 1.34 multiplied by hemoglobin, okay, by saturation. And if saturation is 100%, so it's 1.34 by hemoglobin, okay, and normally it's about 20 milliliter, okay, milliliter of oxygen per deciliter of blood, okay. What's the oxygen delivery? The oxygen delivery, it is the amount of oxygen that delivered to the tissues. What will different about the oxygen delivery and the oxygen content? The oxygen content, it will per fixed amount of blood. Deciliter of blood, 1 liter of blood, 5 liter of blood. But the oxygen delivery, so it is illustrated to the cardiac output, okay, per cycles, okay, or per minute. Cardiac output is per minute. It's the amount of blood per minute, okay. So it will be cardiac output multiplied by what? The oxygen content, okay, of the arteries that will go to the tissues, okay. This oxygen content, why we multiply by 10? Because the oxygen content, as we said, it is 20 milliliter per deciliter. To become for per liter, as we said, will become 200 milliliter per liter, and cardiac output in liter, okay. Change of values. This is cardiac output. What is its value? It is liter per minute, 5 liters per minute. Yes. Oxygen content in milliliter per deciliter. Okay. So if we want it per liter, would be, yes, this is the time. Okay, it will become in liter, because both in liter and this in liter. If we illustrated this, it will be 1.34 by hemoglobin by saturation, and cardiac output will give the oxygen delivery. Let's we'll guess it will how much will be. As we said, this cardiac oxygen content how much? Oxygen content. No, 20. 20. And the venous 15. Okay, and the uptake 5. Okay, so 20 per deciliter or per liter 200. 200 multiplied by 5. 1,000. Okay, so the oxygen delivery will be 1,000 milliliter per liter. Okay, it's clear. So as I said, this is cardiac output is 5. Oxygen deliveries have 1,000. Okay, it's clear. What's the oxygen uptake? as we said, the oxygen uptake, it is the difference between the oxygen content in the arteries and the veins. Yes? The oxygen content in the arteries, how much? 20. Veins, 15. Okay, difference 5 per deciliter, milliliter per deciliter. So per liter will be 5 per deciliter. So per liter will 50. Okay, 50. In cardiac output will be 250. This is per liter. The oxygen uptake will be taken per liter for it, or per body for all the cardiac output. For all the cardiac output. The whole cardiac output is 5. Yes? 5 by 50 will be 25. 250. Okay? So the oxygen uptake is 250. It's clear? So the oxygen extraction, its amount, it's a relation between the oxygen uptake and the oxygen delivery. Okay? The oxygen uptake is how much? 250. Oxygen delivery, 1000. So the ratio will be 25%. It's clear? 25%. تمام؟ خلاص؟ So it is the oxygen extraction ratio, it is 0.2 to 0.3. Okay? So let's take an example for practice. If we have a patient with, this is a normal extraction. Okay? It will depend on what? Will depend on the oxygen delivery. Okay? As you deliver more oxygen, okay, the tissue will take what she needs, what it needs, okay, or what they need. What if the oxygen delivery become low? Patient is shocked, patient is anemic, patient is hypoxic. This is for shock, cardiac output will decrease, anemic hemoglobin will decrease, hypoxic saturation decrease. Okay, so the delivery will decrease. Yes. Okay. Good. So what will occur to the tissues? This will occur to the tissue. Okay. This is oxygen delivery, as we said, and this is the oxygen uptake. VO2 is oxygen uptake. Okay. So as this is here in why it's 60, not 100, 1,000, 600, not 1,000, because it is not milliliter per minute, but per square meter, per surface body area. Okay? Per body surface area. If you want, this is oxygen delivery 1,000 equal about 600 adjusted range. Okay? For surface body area. Okay? And this is oxygen uptake 250 equal about 160 adjusted body area. Okay? So here is this normal? Is this oxygen delivery? Is normal 600. Yes? Okay. The oxygen uptake how much? It's as we say 150, 160. Okay? Okay. And here the saturation artery is about 98% and saturation venous is 73%. Okay? Once you decrease the oxygen delivery, become 500, 400, 300. Okay. What's about the oxygen uptake? Decreased or increased or constant? This is oxygen uptake. It's 150. It's constant. So the tissues will take what they need, and even the delivery decreased. Okay? Forever or to a certain point? Certain point. What is this point? This point where the extraction become maximized. Okay? How they maintain oxygen uptake to become the same? By increasing the extraction from the delivered oxygen. Okay? If you deliver to me more oxygen, 1,000, okay, milliliter of oxygen, I will take my need, which was 250. Okay? If you deliver to me 700, I will also take 250. Okay? What's the difference between both conditions? The percentile of extraction is increased. 250 divided by 1,000, it is 25%. But 250 divided by 750, okay, it will be how much? 33%. Okay, so the extraction ratio increased to what? What is our goal? To maintain the same oxygen uptake. Yes. What's the cut value? The maximum oxygen extraction is 50%. After that will be a tissue hypoxia and death. Why? Because after that the oxygen extraction becomes flow dependent. What's mean by flow dependent? The more you give, the more you give me, the more I will give you. Okay? If you doesn't give me, I will suffer from severe hypoxemia, anoxia, and necrosis and death. Okay? So this is our maximum. Okay? It's clear? So when the tissue will become develop hypoxia and suffer from hypoxia, when the extraction become more than 50. Okay. Yes. How will know the extraction? From this. Oxygen extraction, as we discussed, is the fraction of uptake of oxygen VO2 divided by DO2. The VO2 is normal about 250. DO2 is normal about 1,000. It's about 25 from 20 to the range 230. Okay? As we said, if we put both equations, VO2 equal have the equation. Let's start with DO2. DO2, what's the parameters of DO2? The cardiac output. It's 1.34. It's the hemoglobin. It's the 10 to convert the liter. Okay, and it's the saturation. Arterial, which is the liver. While VO2, it is the same, but the saturation is not arterial. The saturation is the venous, the difference between arterial and venous. So we can cancel both of them above and below. Okay. So the result, the simplified equation, the oxygen extraction will be saturation arterial minus saturation venous divided by the saturation arterial. The saturation arterial is 100, so it's equal just saturation arterial minus saturation venous because it's 1. Yes? So let's practice. Patient in the CCU have MI. Okay, his blood pressure is 90/60. He is on Leukotriex, okay, as adrenaline for support, okay, nootropic support, and his saturation on the monitor is about 100 to simplify, okay. And I want to check if he is well perfused or not. Why I will make? I will take a central venous, or if I can access half Swan-Ganz and I can access a mixed venous, okay. If not, I will take a central venous oxygen mixed, okay. And ask the nurse, please, I want a mixed venous sample for ABG. And I found that the mixed venous is about 65%. Okay, so what is the perfusion status of this patient? Like oxygen extraction and perfusion status. Oxygen extraction will be how? 65, and the arterial is 100. 100 minus 65, so it will be 35. It's normal or increased? It's increased, the normal between 20 and 30. Yes, so increase. So the patient is what? Hypoperfused. So he extract more to maintain his normal uptake. Okay, so I should increase the what? The support. Okay, it's clear? Easy? We discussed this, okay? What's the organ as we asked before, the normal organ, okay, in the or muscle in the body that is flow dependent. Dr. Marwan, no. Do you know? Dr. Marwan, say which organ or muscle? Yes, it's the diaphragm. What is the extraction ratio? Oxygen extraction, how much? It's 80%. Even the heart is 40 to 50. It's the second after the diaphragm. Okay? So it's 80%. So what is the clinical application of this? The patient is shocked. What is the cause of shock? Okay, whatever the cause of shock, we will put him on mechanical ventilation, okay, and sedating the patient and post-pressure ventilation so that we increase the cardiac about 20 to 25%, okay, and the oxygen level to the tissues, okay. Monitoring the oxygen extraction, as we said, okay, the normal how much? 20 to 30, above 30 because decrease in oxygen delivery, so the uptake, so the extraction increased while the uptake is normal, okay? It's clear? Not the uptake increased, the uptake will be constant, okay? The video you can get it, okay, and the presentation, don't write anything, okay? You can get the video and the presentation, okay? What is why the delivery decreased so the extraction increased? From the formula. What's the formula? 1.34, it's a constant, so will not decrease. Hemoglobin decrease, anemia, cardiac output decrease, shock, okay? Saturation decrease, it is hypoxemia, okay? It's clear? An increase in the oxygen extraction, okay, and we didn't write oxygen extraction. We always write the formula, simplified formula, to just remember and remember and remember. It's a saturation anterior minus saturation venous, mixed or central, okay. The oxygen extraction approach 50% indicates either threatened or inadequate tissue oxygenation, okay, and that the patient will dramatically will be expired, okay. A decrease in oxygen saturation can occur in the oxygen extraction, and what it means? Yes, it can occur. When? The extraction will decrease. The extraction will decrease. It will become less than 20%, 15, 10%. The arterial, it will depend on the delivery. Will affect the delivery. What's the extraction? It's arterial minus venous, okay? When this range decrease, if the venous return higher. When the venous will be returned higher, if the tissues didn't consume the oxygen. When the tissue didn't consume the oxygen, not in shock. In tissue hypoxemia, okay? if there is cyanide poisoning, cytotoxic hypoxia, sepsis, there is inflammatory mediators and death of the cells, okay? Or cyanide poisoning, the oxidative enzymes, okay, of the mitochondria are inhibited, so the tissues can't extract oxygen, so the venous return will return with high oxygen content and the difference will be very small and the extraction will be very low, okay? Clear? As in severe sepsis or septic shock or cyanide poisoning, as we oxygen hemoglobin dissociation curve, as we discussed before, it is the relation between the PO2, which is the partial pressure of oxygen, and we said what's the partial pressure and what's the total pressure. The partial pressure is the pressure made by the movement of molecules of oxygen, while the total pressure is the pressure made by the movements of the whole molecules of gases in a space, okay? So normally in this air that are on fire, the oxygen percentile is 0.21, okay? And this one 0.5 is CO2 and most of the gas is nitrogen, okay? So this is the total pressure that is formed by all these gases, okay? And is normally how much total pressure? 760 barometer, okay? Is the normal atmospheric pressure, okay? So the partial pressure of oxygen is the pressure of oxygen that is made by what? By oxygen, movement of molecules of oxygen, okay? And its relation to load, the percentile of hemoglobin that we can, okay? So to load 100%, okay, we need almost, not 100, okay, 90, 95, 98, okay, we need almost about 80 to 90 PO2. To load 50%, we need about 26, 27. Why I choose 50? Because will be a parameter in, okay, you will find in the ABG it is P50. What's mean by P50? It's a pressure, P, it's a partial pressure of oxygen, PO50. Partial pressure of oxygen that can allow to what? To load 50% of hemoglobin. It's normally how much? 26 to 27 millimeter mercury, okay? And its significance I will discuss now. We said discussed why is this is the shape of the curve. Okay, after that, there is shift to the left and shift to the right. This is left, this is right. What's the difference? When you shift the curve to the left, you take the same hemoglobin saturation and you need how many PO2 you need to saturate the same amount of hemoglobin, okay? For about 82. Here normally we need about 50 PO2. Here need, when shift to the left, about 40. What's mean? With lesser PO2, we can load more of oxygen, more of hemoglobin with oxygen. What's mean? That the affinity of hemoglobin to oxygen is higher. Okay? Here, 60. We'll shift to the right. What's mean? That we need more PO2, more pressure of oxygen to load the same amount of hemoglobin. What's mean? That the affinity of hemoglobin to oxygen is lower. Okay? So it is, this is during loading. Let's take it during the unloading. Okay? During the unloading, when the shift to the left, normally during the unloading, okay, here, the patient has how much? 82% of hemoglobin, okay? How much he can unload of hemoglobin to the tissues? 50 PO2, yes. Why? When the shift to the left, okay, how much he can at the same hemoglobin saturation can unload to the tissues? It's 40, okay? Because his affinity to oxygen is higher, okay? And here, he can unload to the tissue, it's 6, okay? Because this is a physiological process that occurs at the lung and the tissue, in the periphery. At the lung, you expect to be shift to the left or shift to the right? At the lung, you expect the curve to shift to the left or shift to the right? Left, excellent. Why? Because at the lung, the affinity for oxygen increase to load oxygen, more oxygen with lesser pressure, okay? Even with 20 or 30, I can unload most of the hemoglobin, okay? But at the tissues, to the right, okay? To unload almost all of my hemoglobin, my oxygen to the tissue, okay? It's clear? So we can, this process, okay, what is shifting to the left and what make it shift to the right? What make it shift to the left? Everything decrease. Decrease in temperature, decrease in DPG, decrease in pH, not in pH, in hydrogen, yes? Decrease in hydrogen, make it increase in pH. Decrease in CO2, all of this occur at the lung, okay? Why at the tissues, increase all of them. Metabolism lead to increase of temperature, increase of DPG, and we will illustrate it. Increase in hydrogen, that will be decrease in pH, and increase in CO2 from metabolism leads also to decrease in pH. Okay? So we'll shift to the right. It's clear? Okay. What's DPG? This was a gift for. What's DPG? DPG.
Yeah.
And what's important? Okay. It is 2, 3, di, D for di. Phosphatidide, phosphoglycerol. What's this important? It's an intermediate, okay, in glycolysis. What's its importance? No. During the metabolism, glycolysis an intermediate factor, okay, what is important? No. It's important that there is a receptor for DPG on beta chain, okay, of hemoglobin. So, the more it increased, bind to DPG, to the receptors, and load hemoglobin at the tissues. The lesser the amount, okay, so the affinity increased and load oxygen at the lung. Okay? So the second question. Can you expect the curve of fetal hemoglobin? High affinity, yes. Excellent. So it will be left or right? Left. Excellent. Okay. How do you expect it? The curve will be almost right angle. Will be this and okay. Why? Because very high affinity with minimal pressure of PO2 can load almost of the hemoglobin. This is a gift from Allah to the baby in his abdomen, okay, or in the uterus of his mother. With very minimal oxygen from the placenta, okay, he can load all of his hemoglobin. This is for okay, the person who answered this question. Why the hemoglobin F, okay, this curve and shift to the left, and this high affinity, which is gifted from Allah?
Because the fetus
Yes.
doesn't depend on the oxygen.
Yes. And what? And then
It needs the fusion or fusion from the placenta or the mother's.
yes, he take oxygen for by diffusion from the mother. Why he can? Why his hemoglobin? The question is about his hemoglobin. Why his hemoglobin has shift to the left and high affinity for oxygen? It's a bio. What's the difference between fetal hemoglobin and adult hemoglobin? The molecule in what? The change. Wait. What's the difference between change in adult and fetal? What's the difference? What's the difference? Tell the adult. Yes, alpha or beta. And then, what's the difference between the fetal and the adult? Different chain, alpha or beta, okay, and then, what's the difference between the alpha or beta? No, it's amino acid difference. Okay? The difference between fetal hemoglobin and adult hemoglobin is amino acid difference. Okay? What's amino acid difference? It's a monomic. Okay? For babies, they are soft babies. So they contain serine. Okay? S for soft. For adults, they are hard adults. So it contains serine. What's the difference between serine and serine? Serine has no or very, very minimal receptor for DPG. So it doesn't, okay, attach it to DPG. Okay, so it's unload oxygen body, very high affinity oxygen and body. Okay? Okay, do you know the history of DPG and its importance? It's clear? So serine in soft babies contain very minimal amount of oxygen, of DPG receptor, so it has very high affinity to oxygen and they can be almost right angle. Okay? Clear, Dr. Marwan? We discussed here the oxygen curve, as you know, خلاص, it is between PO2 and the hemoglobin saturation. It is how many PO2 you need to saturate the desired amount of hemoglobin. The oxyhemoglobin saturation, it is the amount of oxyhemoglobin saturated with oxygen compared to the total amount. Okay? If it's 100%, so all of your hemoglobin is saturated with oxygen, it's 50% of your hemoglobin saturated with oxygen. Okay? 2 to 3 points considered here. Okay? The curve, as we said in the first, it is sigmoid shape because we have 4 atoms of iron in each molecule of hemoglobin, and they are, as we okay, have this ions, the receptors are inside. Okay, so the first molecule of oxygen to bind is very difficult. Once attached, there will be conformational change, and the receptors will move out, so can be easily connect and bind to oxygen. So this is more of this plateau part, and this is the steep part after the conformation change, after the first oxygen molecule bind, and this is after which is circulating. Okay, and then we discussed the that there is a shift to the left and shift to the right. Okay, shift to the left, as we said, if we have 80% of hemoglobin saturated, how much PO2 is needed to saturate this amount of hemoglobin? Normally about 50, okay? 50 PO2 needed to saturate 80% of hemoglobin. If we shift to the left, okay, so I need only 40 to saturate the same amount, okay? So what's mean for you that I need only 40 to load the same 80% of hemoglobin, that the affinity here for of hemoglobin for oxygen is higher, okay? While here, when shift to the left, I need more oxygen, so the hemoglobin is more PO2, so more power, more pressure to load the same amount of oxygen to hemoglobin. So I need, so this means that the affinity of hemoglobin to oxygen is missing. Okay, this is a physiological process. Okay, shifting to the left and shifting to the right. Okay, at the lung and the tissues. Okay, at the lung you will expect to be left or right.
Sorry?
At the lung you expect the curve to be shifted to left or the right. To the right. At the lung the affinity for hemoglobin increased or decreased. The loading increased. So when we shift to the left with the minimum amount of PO2, okay, we can saturate almost all of the hemoglobin. Okay, while at the tissues, I want to unload the carried hemoglobin oxygen to the tissues, so will be shift to the right. Okay. Okay, and the last thing that there is a parameter which is you can find in your ABG is PO50. Okay, what's PO50? It is the amount, the PO2 50. PO2 is the pressure of oxygen needed to saturate 50% of hemoglobin. Normally about 26 to 27 millimeter mercury. Okay, what's its importance? Let's discuss it. What's the importance of PO2? This for who answer. As this. We will. Okay. We will draw these lines here instead of this. What is important? It's an objective evidence of shifting to the right or shifting to the left. If the patient, his P50 is 20 or 15, so it will be shift to the right or shift to the left? Shift to the left, X. If it become 40, so it's shift to the right. Okay? Okay, it is clinical practice and its clinical application to detect which type of hypoxemia. Okay? Clear? So if the patient has cytotoxic hypoxia, okay, it's considered to be shift to the right or shift to the left? Carbon monoxide poisoning. Yes, excellent. Shift to the left because carboxyl has very high affinity to oxygen and it will not leave it to deliver to the tissue or unload it. Okay, so will be shift to the left and you will find your PO2 50. How much? Even 10 or 12? Yes, not to 26 to 27. Okay, it's clear. AV gradient. What is AV gradient? It's alveolar arterial gradient. What's mean by the alveolar arterial gradient? It is a gradient, as we discussed before, everything in this world, okay, Allah makes it to pass was gradient, okay? Diffusion is gradient, everything, okay? So if I wind with gradient, why wind is created? Because there is a difference between the gradient of pressure of air from one part to another. Okay? How? When there is cold atmosphere, okay, the cold atmosphere will make the molecules to have condensed, okay, to each other, and their pressure will be higher, okay, condensed but with higher pressure. While with the atmosphere is hot, they will be diffused, okay, and with lesser pressure. So the air will come from higher to lesser pressure and wind is created. Okay? Everything. Okay? So why oxygen, how oxygen go to our cells? The first, okay, in front of our nose, okay, there is an inspired air. After that, we will go to inside the nose. What will occur? What's the process will occur inside the nose? Filtration and what? Humidification. Okay? So the pressure of oxygen will decrease by how much? By the pressure of water associated with. Okay? Here, outside is only oxygen. Okay? And inside our nose will be, and the respiratory tract will be oxygen plus water. So the pressure of oxygen will be lesser. Okay? So the flow will be from outside to inside. Okay? Then in our alveoli, active movement also. What is the pressure gradient? The active movement will make a negative pressure to become a pressure gradient. Okay? Okay. But if someone who have no active movement, okay? Yes, with pressure gradient will move. So, and in our alveoli, the CO2, how much? Is about PCO2 about 40. Okay? So the pressure of oxygen will be lesser. Okay? So the alveolar pressure of oxygen, how you expect the formula will be? The alveolar pressure, it's a scale. Okay? No, it's not present here, the scale. Okay. So the alveolar pressure, okay, will be, so let's resemble it by numbers. The A gradient, A capital for alveoli, A small for arterial, okay? So it will be the arterial PO2 pressure of alveolar pressure of oxygen minus the arterial pressure of oxygen. It's clear? Okay. The alveolar pressure of oxygen, this is in the ABG, okay? It's not difficult. But the alveolar pressure of oxygen may be inside, maybe find in the ABG, okay? If not find, we can calculate it. What's the parameter that it will depend on? The parameter, the first, okay, will be the atmospheric pressure is constant. How much? 760. Okay? Okay. Then 760 is, what is the 760? Is the total pressure, not the partial pressure. Total pressure that's formed by. It's the total pressure. The total pressure that is formed by oxygen, CO2, nitrogen, and water. Okay? So, the partial pressure of oxygen will be what? Percentile of the gas in the total pressure. So, it's 0.21, it's the concentration of oxygen. So, the pressure of oxygen will be 0.21 multiplied by 760 is the total atmospheric pressure. Okay? It's clear or not? Not. Okay. Total pressure is the pressure formed by all gases. Okay, including nitrogen, oxygen, CO2. Okay? So what is the pressure formed by oxygen only? It's a type of oxygen in this space, okay, by the total pressure formed by the all gases. Yes? So it's 0.21 by 760. It's clear? Okay. So FiO2 by atmospheric pressure. Okay? We subtracted pressure of water from the atmospheric pressure because we said that what in our nose and the respiratory tract that oxygen will be humidified. Yes? So we subtracted the pressure of what? Of water. It's clear? So the pressure of oxygen in the alveoli, hello, at our nose will be FiO2 in barometric pressure. Outside our nose and our body. Inside the nose and the respiratory tract will be FiO2 by atmospheric pressure minus water pressure. How much atmospheric pressure? 760. How much water pressure? 47. So at the sea level will be this 730 constant. Okay? FiO2 how much? 0.21. So at sea level and FiO2 normal at the room air, how much will be this? 150 constant. Okay? But I illustrate from we gain 150. Okay? We get 150. Minus. Under the oxygen reached the alveoli, we will find CO2. Okay? With high concentration. Okay? Not outside and not as the air. The air 0.5. Okay? So the pressure of oxygen inside the alveoli will be higher or in the or at the nose or outside. At the alveoli will be higher or lesser, Dr. Marwan? Lesser. Yes. Okay. So the gradient. Okay. So it's very lesser. By how much? Lesser. By how much? By the pressure made by the PCO2. Okay. So equal to PCO2 multiplied by 0.8. Okay? It's clear? So all of this is the alveolar pressure. Minus the PO2 will be the A grade. Okay? It's clear? 150, as we said, with this all of those. Okay, 47, 70, 90, and 0.1. And this is PCO2. From this equation, what we can suggest when the gradient increase and when it decrease. When the pulmonary disaffection, what will occur? It will affect the alveolar or the arterial? Arterial, but the alveolar is constant. Okay? If there is diffusion, okay? If there is problem in diffusion. But if there is a problem in ventilation, COPD, asthma, what will occur? The CO2 will rise. Once the CO2 will rise, what about the alveolar oxygen pressure? Miguel, yes, excellent. Because the CO2 molecules is much higher. So the pressure of oxygen in the alveoli will be lesser. So easy. Just understand what's this and you will, okay, you will excel. So if the patient has hypoventilation, the alveolar gradient will be, the alveolar pressure will be lesser. Okay? It's clear? Okay. And the PO2 also will be, arterial will be lesser because the alveolar decreased, so the gradient decreased. Okay? It's clear? Okay. One moment. One moment. Hello? تتكلم يعني لا تبعتيه وللنيرس لا يبعته غير لما تكلم الدكتور فايز. Once you can contact دكتور فايز وهو يجي take a decision ابعتيه. انت فاهماني ولا لا؟ قولي له بس احنا الدكتور فايز كونسلتنت في العمليه وانس بيخلص بنعرف بنحكيك بنحكي لك اول شو كان بس عشان مش عارفين نوصل له عشان هم حقهم في العمليات. ما في مشكله دكتور. ماشي انت ممكن ايش هو خلاص هو اكل خلاص ماشي هو لو اكل هو ممكن اي شيء البيشنت لو بده اياه ممكن يعمل خلاص لو هو جعان على الاخر وبده ياكل ممكن ياكل خلاص هو يتاجل خلاص. فانكشن كام؟ كام؟ 25 اوكي نفس البروتوكول هيكون 75 صوديوم بايكارب بلس 75 sodium bicarb plus 425 D5 X root 5 is 425 D5 X root 5 okay but by a rate 0.5 milliliter per kg per hour milliliter per kg per hour. بقى هو الريت عشان الفانكشن 25 خلاص ان شاء الله. لا كلميهم وخليهم الدوكيومنت. اوكي شكرا. Okay, so this is the A grade. What's hypoxia? Hypoxia is defined as deficiency of either delivery or utilization of oxygen at both. So it is if delivery decreased, okay, or utilization decreased. Delivery will decrease by which means by hypoxic. Hypoxic oxygen itself will be decreased either high altitude, so the barometric pressure will decrease and alveolar pressure will decrease. Yes, okay, or what? Or lung problem will cause hypoxia, so the diffusion will decrease. Hyperventilation problem, so too will increase. So the alveolar pressure will decrease, so the gradient will decrease, so the CO2 will decrease. On the screen, yes, okay. So it is hypoxia, or after if no problem in the lung and all of oxygen by the gradient diffused, okay. So what will occur? You are waiting for the carriers, okay. The carriers are ready, are enough or not. If not enough, so it's anemic hypoxia, okay. If it's enough but they are not well functioning, so it's hypoxia or metahemoglobin. So it's also anemic hypoxia, either functional or amount. Okay? The hemoglobin is enough as amount, but its function is poor. In hypoxia, in anemic hypoxia, but it's carboxyhemoglobin or methemoglobin. Okay? Carboxyhemoglobin, carbon monoxide, okay, or methemoglobin was nitrites and okay, cause methemoglobinemia. After that, the carriers are enough in amount and function. So what's the next step? They will go in the road. Okay? The road is bad. The cardiac output is low. So will be stagnant hypoxia. The road is bad. Okay? Either generalized because cardiac output or localized because vasospasm or other thing. Okay? Stagnant hypoxia. All thing is okay and the road is good. And the carriers went to the tissues. Okay? This has a problem. Okay? So they can't gain and consume oxygen, so it is cytotoxic hypoxia or tissue hypoxia. Okay? It's clear? Just a story. Okay? Parameters, classification, etiology, mechanism of hypoxia, alteration and metabolism in the body, and pathophysiological base. Parameters. What's these parameters? PO2, partial pressure of oxygen. And all of us know what's the partial pressure and what's the total pressure and what is mean and what's the relation to the hemoglobin and how we can hemoglobin circulation, oxygen here, shift to the right, shift to the left. The lesser PO2 that can load more oxygen, so it is shift to the left. The more PO2 needed to load the same amount of hemoglobin, so it is shift to the right. Okay? CO2 max, okay, it is totally dashed. Okay, so it is the oxygen content of maximum oxygen content. What's mean by this? It's the maximum oxygen, maximum content of oxygen with high saturation and maximum hemoglobin. Okay, if it has normal hemoglobin, has maximum saturation, what is the CO2 max? Okay, the oxygen content. Okay, CO2 is the oxygen content, saturation, and P50 as we discussed. Okay, 26 to 27, and it is the pressure of oxygen. Okay, pressure of oxygen needed to saturate 50% of hemoglobin. Here we'll illustrate briefly if the saying PO2 partial pressure of oxygen is the tension produced by oxygen molecules physically dissolved in plasma. Everything is clear. Okay? Normal PO2 is arterial 100, venous 40 millimeter mercury, determined by the PiO2, which is the inspired oxygen, okay, and pulmonary function. If the inspired oxygen is decreased due to anything, due to hypoventilation, CO2 decrease, okay, or high altitude, okay, atmospheric pressure decrease, okay, anything in the formula, okay, so will be inspired oxygen in the alveolar will decrease. Or pulmonary function, if the alveolar oxygen pressure is normal, okay, but the lung is bad and there is any problem and can diffuse oxygen through it to the pulmonary capillaries, so also will be decrease in the arterial PaO2, the oxygen content. This is the oxygen content, include, as we said before, just a revision, oxygen that bound, that plus dissolved, it's normal about 20, and the venous about 15, okay, and the difference about how much? 5, which is uptaken. It's a revision, yes? The oxygen content determined by what? The PO2 and the CO2 max. Okay? The higher the PO2, the higher will be the oxygen content. Okay? But it is a very minimal, okay, change, because it is considered the dissolved, okay, but this dissolved will carry oxygen through hemoglobin. Without this, hemoglobin will not, oxygen will not reach to the hemoglobin, okay, as oxygen will not jump from the alveoli to the hemoglobin. He must pass to the plasma, dissolve it, and carried on the hemoglobin by the gradient. Okay? And this is the CO2 max considering about the hemoglobin. Okay? Okay, it's the maximum. And the AV arteriovenous oxygen content difference reflects the oxygen volume of the tissue uptake. As we said, that it's 5. Okay? 5 milliliter per deciliter, or 50 per liter, or 215 per cardiac output. Yes? It's 215. Oxygen saturation, as we said, the percentage of hemoglobin presented as oxygen hemoglobin, normally 95 and venous is 75, and the difference will be the extraction from 20 to how much to 30. Yes? Increased with decreased delivery, extraction, and decreased with cytotoxic hypoxia. P15, as we said, means oxygen partial pressure required to saturate how much? 50% of the hemoglobin, which reflects the affinity of hemoglobin for oxygen, and its practice, a practical point of view, it's as objective evidence for us to know shifting to the right or shifting to the left. The lesser the PO2, left, yes, the greater to the right. The lesser here will be shifted to the left. The greater will be shifted to the right. Normally 26 to 27 millimeter mercury. This is illustrated many times, okay, to show just the view. Classification and etiology, this is the 4 types: hypoxic, hemic, circulatory, heterogeneous hypoxia. Okay. What's anoxia? Anoxia, that is no oxygen at all left in the tissues. Hypoxic hypoxia, as we said, the PO2 of the arterial blood gas is reduced, so the oxygen pressure is reduced. Anemic hypoxia, the PO2 is normal, but the hemoglobin available to carry oxygen is reduced, either functioning or what? Or amount. Stagnant hypoxia, okay, the blood flow to the tissues is low, okay, either generalized cardiac output, okay, cardiac, or localized stenosis or anything, okay, or embolism, despite a normal PO2 and hemoglobin. So the first, the problem only in the PO2. Hypoxic hypoxia is the problem only in the PO2. Yes? But cardiac output is normal, hemoglobin is normal, carrying capacity is normal, everything is normal. The problem is in the what? In the PO2. It's hypoxic hypoxia. The first step. Second step is anemic. Anemic hypoxia. PO2 is normal. But what's the problem? Hemoglobin. Okay? And the cardiac output is normal. From the name, anemic hypoxia, those are problem in the hemoglobin. So the problem will be in the CO2, which is the oxygen content, while the PO2 is normal, okay? And the cardiac output is normal. Stagnant or ischemic hypoxia, well, both are normal. The PO2 is normal, the hemoglobin is normal, but the cardiac output is decreased, okay? As the blood flow to the tissues is low, okay, that adequate oxygen is not delivered to it despite a normal PO2 and hemoglobin concentration. Okay, it's clear? Histotoxic hypoxia, amount of oxygen delivered to the tissues is adequate, hemoglobin normal, cardiac output normal, PO2 normal, but tissue cells can't make use of oxygen supplied to them. So we know it from what? From where we can know that is histotoxic hypoxia? From where? We said it. His toxic hypoxia, no consumption of oxygen. So the venous return will contain high oxygen. So the extraction will be low. Arterial minus venous, less than 20. Yes? X. Okay? So it's a toxic hypoxia or sepsis. Okay, cause of hypoxia, less oxygen in the inspired air, as we said, as in high altitude due to. In high altitude due to what?
What is that?
Not high altitude, less oxygen in the inspired air. Why? Polycythemia is a secondary compensatory mechanism to compensate that. Okay. Why less oxygen in the inspired air in high altitude? Yes, atmospheric pressure decrease. So the alveolar pressure of oxygen will be decreased. So once alveolar pressure decrease, so the gradient will be decreased. So, okay, so the amount of oxygen that passes through the blood will decrease. So it will get hypoxia. It's clear or not? It's not clear. High altitude, okay? What about the barometric pressure, atmospheric pressure? Decrease. Right, you decrease the pressure, okay? So when decreases, what will occur? The formula of the air gradient. When the barometric pressure decreases, what will occur? This is decreased. It's not 760, it's 600 only, okay? So what will occur? So what will occur if it's 600 only? If not, become 150. It will become less. So the PO2, the alveolar oxygen pressure, decrease. And as we discussed, everything with gradient. Once it decreases, the gradient between it and the capillaries, pulmonary capillaries, will be decreased. So the PO2 will also decrease because the gradient decreases. Okay?
Requested. I request all the indications. No problem. I will request that. For the
Okay. In closed room, why? Why is there less oxygen in inspired air in the closed room? It's the same. Closed room will be increased CO2, increase other molecules than oxygen. So the pressure of oxygen, the total pressure is constant, but the pressure of oxygen will decrease. So the inspired alveolar oxygen pressure will decrease. So the gradient decrease. So CO2 will decrease. Okay, in the artery. It's clear? It's the formula, and you will see the parameters of the formula. Once it decreases, you will decrease. The second thing is decrease in the pulmonary ventilation. What does it mean? Decrease in CO2. When decrease in CO2, so the pressure of oxygen will decrease in the alveolar, so the gradient will decrease. Okay? It's clear? Defective gas exchange and oxygen transfer in a respiratory membrane as pulmonary edema, cardiogenic or non-cardiogenic ARDS, or pneumonia or collapse or anything. Okay? So what will occur? Alveolar pressure is normal. Okay? Once the alveolar pressure is normal, but the PO2 will what occur? Decreased. The arterial decreased. Why? Because there are problem in diffusion. What's the difference between this and number 2 and number 1? How you can know there is a problem here or in this? There is no problem in CO2 here. Here there is a problem in CO2, yes. Okay. And first one, there is no problem in CO2. What's the problem? How between number 1 and number 3? How I can? No. from the AA gradient, alveolar arterial gradient. Number one, the gradient will be normal. Yes? The alveolar inspired air decrease, so the gradient decreased and the PO2 decreased. But the gradient between the alveolar and the arterial are normal. Okay? Both are decreased. Here, defective gas exchange, the alveolar air pressure will be normal, but the arterial will be low, so the gradient will be high. You don't understand this. Okay. We have, as we said, alveolar air will go inside by, let's say, any number, okay? 109, okay? 110 atmospheric pressure in the alveolar. This is the alveolar airway pressure for me, okay? So, and in my capillaries, right, the PO2 is about 8, 7. So there is a gradient 40, and the air will go across the transpulmonary capillary membrane to the blood, to the capillaries. Okay? So the arterial will become saturated, okay, and PO2 in the arterial increase to become 100. So the gradient between the alveolar and arterial PO2 will be 10. It's normal. Okay? The 70 or 60, it was the means, okay? Okay? So it is normal gradient 10. Okay? The alveolar is 110, and the capillaries, the arterial is 100, so the gradient is 10. It's normal. Okay? Let's take another example. Patient has pneumonia or pulmonary edema. Okay? Pneumonia or pulmonary edema. The alveolar pressure, the alveolar oxygen pressure have PA capital O2, how much? 110. There is no problem here, no CO2, no increase at high altitude, no anything. Okay? But then problem in the membrane, so the diffusion increase. So the arterial will be 7, 8, so the gradient will be 4, so it will be high. There is a problem in the diffusion. Yes? Okay? Okay, it's clear? So I know I can differentiate between the pose and between both of them by the AA gradient. It's clear? The defective ventilation perfusion ratio due to uneven alveolar ventilation as in asthma or emphysema or pulmonary fibrosis, or due to non-uniform pulmonary blood flow as anatomical shunt, fallot or tautology. In the fallot or the shunt, what do you expect the gradient? High or low? AA gradient. Very high. X. Why? Alveolar is normal. There is no problem in the lung or the altitude, atmospheric pressure or the CO2. There is no problem. Membrane is normal. Okay? But there is a problem that there is a shunt between right side and left side of the heart. Okay? Arterial, venous and arterial. Okay? So always there will be a shunt. Okay? If it's right to left shunt, it's a problem because there will be deoxygenated blood shunted to the right side, and it's always hypoxemic, whatever the, and it will not respond to oxygen. What's the difference between in hypoxia? If there is a response to oxygen, high hyperbaric oxygen or oxygen with high concentration, so it's correctable as pneumonia or any problem in the membrane or anything. It's not correctable to oxygen, it is a shunt. Shunt may be due to cardiac shunt or maybe due to pulmonary shunt, what is uneven alveolar ventilation. okay, as in asthma or emphysema or pulmonary fibrosis. When it occurs, what will occur in uneven alveolar ventilation? Yes. There are two types of shunt. Anatomical shunts, okay, for cardiology, okay, and this is a functional shunt, okay, for respiratory. What's the problem in the functional shunt? When there is a lobar collapse, lobar pneumonia, okay, what's the problem? Busy? Yes, the problem is because unequal, okay? When it's unequal, there is the alveolar ventilation unequal, there is a shunt. Why? Because the blood goes, okay, to unventilated area. So there's no gradient, and this unventilated area contains high CO2 and no oxygen pressure. So there's no gradient, so it's as if it is shunt, okay? No oxygen will pass from the lung to the blood, okay? The blood comes without oxygen and goes without oxygen, okay? Clear? As if it not pass on the lung, okay, ما عدى على اللنج، اجى ومشي وما اخذ اي شيء لان هو ايه ما في جريدينت الاكسجين، تمام. It's incompatible with life if it's total lung but it's partial. Picture of hypoxic hypoxia. Practice. This is a normal and this is the HH. Normal PO2, arterial and venous. 95, 4. 95 you expect to. How much will be the saturation? In the plateau phase, 97, 98, 99. Yes. Almost over 80. It's above 95, okay? In the plateau phase, okay? The 97, okay? The venous, 4. How much you will expect? We say that 60 equal 90% saturation. Yes. 40 in the sleep portion. Yes, 75, excellent. Okay. Oxygen content, how much? Normal, 19 or 20, and the venous 40 or 50. Okay, it's the normal. Oxygen used or uptaken by tissues? High, yes, excellent. Arterial venous PO2 difference is 55. Okay. Extraction. Consider it as 100. Okay. More than 70. حرام عليك. الإيكويشن إيش؟ arterial minus venous saturation. صح؟ مش هي كده؟ ميكس الفينوس عندي 97 ناقص 45 كام؟ 22. 22. It's normal between 20 and 30. Yes? Saturation extraction normal between 20 and 30. لو فوق ال 30 يبقى الدليفري الواصل قليل وبالتالي بعمل اكستراكشن اعلى. لو اقل من 20 يبقى في مشكله في التيشوز فبعمل تعمل اكستراكشن توصل ل 6 اوكسيد وبترجع لهاي اوكسيد كونتنت في البينز. تمام؟ واصله ولا لا؟ تمام. That's hypoxic hypoxia. PO2 40 arterial 25 venous. Okay. Hemoglobin saturation, oxygen saturation 40 75 25 45 saturation 45 saturation. Okay. Oxygen content 14. Okay. دي بيعبر عنها انه ضرب في الهيموجلوبين، احنا مش عارفين الهيموجلوبين كام. اوكي، لو هو بيعتبر الهيموجلوبين نورمال في الناحيتين يعني 14 و9. اوكي، oxygen used by the tissues the uptake is constant 5 مللي. مش عارف اتفقنا ان الكيرف كان عامل هيك ونزل كونستانت لغايه ما يحصل الماكسيمم اكستراكشن. مش ده اللي اتفقنا عليه؟ 5 مللي صح ولا غلط؟ اكستراكشن كام لغايه ما ارد بس على الرقم ده؟ اكستراكشن كام صح؟ Yes, sir. Okay, it's a high note. Okay. It's cert. Hello? It's not cert. Hello? أيوه. بيسأل الدكتور بخاري يقول لهم عايز اتكلم دكتور بخاري عشان فيها كذا، فيها كام امر احكيهم عليه بس، ومش عارف اوصل له بقى، برن عليه ورن له على الموبايل. لو هو خلص وبيقول لك نزلها كلميه هيكون خلص، رن له على الموبايل. ما تنزلها غير لما تحكي له. تمام، طب بقول لهم انا بدي احكي قبل ما انزلها. كام؟ 80. ما انا عارف. ماشي، بس هو مع الكونتراست هتخش فيري هارد. ماشي كلميه اول، انت بس كل قصه بتكلميه. اول ما قال لك ما تاجليها كلميه، قال لك اجليها اجليها، ما تاجليها نزلي بس. كلميه على الكاس. الكاس ليهم 4 ارقام ممكن اصل هو او 5 ارقام، خلاص هو بيكون جنب واحد فيهم. اوكي شكرا. تمام. الاكستراكشن انت قلت كده سيرت غلط. ليه؟ The simplified formula if the saturation arterial is 100. The formula is arterial minus venous divided by the delivery which is arterial. It's not 100. It is 75. So it will be how much? 40. Okay. احسب على الكالكوليتر. 75 ناقص 45 بكام؟ 30 على 75 من 100 كام؟ 30 على 75 من 100 40. لا هي تلت. So the extraction will be higher to maintain the same uptake. Okay? It's clear? تمام؟ It's 4. It's higher because the liver is decreased. Okay? The AV PO2 difference is very low. Okay, small. Characteristics of hypoxia, low arterial PO2 as we said, low oxygen saturation of hemoglobin, low oxygen saturation of hemoglobin as we said. Okay, low content of oxygen. Okay, high extraction to maintain the same uptake. Okay, it's not written here. Okay, and the low arteriovenous PO2 difference. Okay, انه جريدينت مقلب. باس فيسيولوجي هيبوكسيا زي ما حكينا via peripheral chemoreceptors. خلاص هيحصل stimulation respiration to increase the PO2. Okay, but wash out of CO2. So less CO2. less CO2 هيعمل ايه الاكسجين هرمون كيرف؟ decrease. will shift the curve to the ايه؟ everything decrease. will shift left to the left. So less release of oxygen to the tissue, so tissue hypoxemia occur. Eh? It's physiology. Okay. ماشي حاضر خلاص.